For our next speaker, my pleasure to introduce Dr. Michael Sabel in the Department of Surgery and the Chief of the Division of Surgical Oncology. He's been a colleague for probably greater than 10 years, fantastic partner in the melanoma world, and he's going to talk to you today about some new data related to surgery for melanoma.
So before I get into that, I just will mention, just to dovetail on what Dr. Harms was speaking about, we do have a mobile technology, an app called Skin Check. So for those of you who struggle to remember to do your skin exams or need help doing the skin exams, it's a free download on both iTunes and Android. We have flyers out here. Those of you watching on the live stream can just go over to the App Store and download it. Not right now, not during my talk. Anyway, so what I'd like to talk to you a little bit about is some of the changes in the surgical management that have been getting a lot of questions from patients. Has always been a struggle for us in terms of when do we remove all of the lymph nodes in a patient with melanoma. And this has recently brought back out into the limelight because we have some new research data that I'm going to go through in a little bit of detail. But what I really want to sort of accomplish in this talk is helping you understand a little bit why we still struggle with this question after almost 50 years of trying to figure out what it is we're supposed to be doing with the lymph nodes. Every time we get a little bit closer, we sort of open up more questions. And one of the most common, when I'm having this conversation with patients, one of the most common responses I get after sort of laying out all of the information is, what should I do? Patients sort of say, just tell me, should I do the node dissection? Should I not do the node dissection? Or the other way of saying that, what would you do? What if it was your father? What if it was your wife? And I have to say, I would lay out the information the same way because this is challenging. Every time we get one answer, it raises a few more questions. And so what I'd like to do is paint this a little bit with the history of where we've evolved to this point, and then show you some of the most recent data that we have. And so, as everybody's aware, melanoma can metastasize to the draining lymph nodes. It's one of the first places melanoma does spread to if it is going to spread. And there's multiple nodes, and it's a rather complex pathway by which these nodes spread, and so it can spread to one node, it can spread to multiple nodes. And so, early on in the treatment of melanoma, many years ago, it was just routine for every patient, whether we knew they had melanoma in their lymph nodes or not. So some patients you can feel a large lymph node and you suspect or you can prove by a biopsy that they have melanoma in their nodes. But other patients, you feel their lymph nodes, you don't feel anything abnormal, but that doesn't mean that there aren't microscopic cells in the lymph nodes. And so because of this risk, again, when I was sort of in training, every patient with melanoma was being recommended to go to the operating room. We would do the very wide margin excision in order to control the local disease. And at that time, we would also remove all of their lymph nodes. We would do a complete lymph node dissection. So this could be the neck, it could be underneath the arm, it could be down here in the groin. Now, the goal here was to control the disease, but the reality is that most patients who present with melanoma, they don't have that microscopic disease in their lymph nodes. And so 80% of patients were node negative, which means if we're removing that microscopic disease, it's only in about 20% of patients that we are helping those patients. And so this is a very common dilemma in the management of cancer. And this is going to be a theme that you're going to see throughout all of the talks today. We have a procedure that can potentially benefit a few patients. It has side effects. And so do we expose everybody to those side effects in order to benefit a smaller number? And what is that number? Is it worth it for 1 patient out of 100, 5 patients out of 100, 10 patients out of 100? And those are not easy questions to answer. But we were taking out the lymph nodes in everybody, which means everybody was exposed to those risks. And the biggest risk that we talk about is when you're doing it underneath the arm or in the groin, it's the lymphedema, the swelling of that extremity, which is unfortunately not curable. It may be manageable in most cases, but we can't rid you of lymphedema if it does occur. And so that's sort of the bigger risk long term. But there are other risks of doing the surgery besides lymphedema. There are nerves in the area, so the surgery can leave you numb in an area, or it can affect the way that you move with that arm or with that leg, and you can have dysmotility problems, and there's pain and there's inconvenience related to surgery that we need to think about. The other thing that was challenging in melanoma is it's easy to know where it drained to maybe if it's on the arm, but what about a melanoma here in the chest? Do you take out both sets of lymph nodes? What about right here on the flank? Do you take out both underneath the arm and the legs? So we really struggled with this idea for quite a while. And so there was large push to sort of say maybe we should do delayed node dissections. If we don't see any evidence of cancer in the lymph nodes, let's do the wide excision, but let's just watch those patients, knowing that those 20% of patients are eventually going to have that disease grow to the point that we can feel it. And this would be the time to then go back and do that dissection. But the worry was, in the time it took that microscopic metastasis to get to the point that it was big enough that we could feel it on a physical examination, it might start to spread from that node to other parts of the body, meaning we might have lost an opportunity to cure those patients by not doing the surgery earlier. Now, this was all changed when sentinel lymph node biopsy came into play, because now we had a way to identify those patients who had microscopic disease in the lymph nodes without putting them through the major dissection by injecting a tracer at the site of the melanoma. That tracer now travels to the nodes that first received drainage, and we can identify that node, take it out, and now we know. So if that node is negative, we can spare the patients the morbidity of that complete dissection. But now we go back, we do the wide excision. If the sentinel node was positive, we now struggle with that same question. We know that some of those patients have disease in the sentinel node, may also have disease in what we would call the non-sentinel nodes, the ones we didn't take out at the sentinel node biopsy. We only take out the nodes that take up the tracer. So if the melanoma has spread from a node that takes up the tracer to a node that doesn't take up the tracer, we would have left that behind. And so the routine had been for every patient with a positive node to go back to the operating room and again remove all of those lymph nodes. Same idea. We know a small percentage, and again, the number was about 15 to 20%, would have disease in the other lymph nodes. We're trying to capture those, but we have to expose everybody with a positive sentinel node to the risks of the surgery. And this was frustrating, because many times you would get a pathology report back that would say 0 of 20 nodes, 0 of 30 nodes. And you'd have to question, why did we do that? Did we really help the patient by going back and doing that? All right? It's not so simple as this. Because just because we get a report back that says 0 of 20 nodes doesn't mean there wasn't melanoma in those other lymph nodes. It's really impossible for us to scrutinize those nodes so carefully that a report that says 0 really means there wasn't a cell that was destined to come back. But nonetheless, a lot of people started saying maybe we don't need to be doing the dissection in every patient. And this led to several papers where a group started to look backwards. And they started to look at all the patients that we did the node dissection on and all the patients that we did not do the node dissection on and say, are we really helping those patients by doing the dissection? And these are what we would call retrospective studies. And these are just two examples, one from the Netherlands, one from here in the United States, for which University of Michigan was a partner in. And they looked at this and they said, there really doesn't seem to be a big difference in survival, meaning the patients who decided not to have the surgery, all right, didn't seem to be doing that much worse. And you can see here on the left, that top graph is nodal recurrences. How many patients had the cancer come back in the nodes? And about 15% of patients, 15% more, who did not have the surgery would have the lymph nodes come back. But the survival seemed to be about the same. Now, these are retrospective studies. These are looking backwards. And the problem with that is there's a bias. And it's what we call a selection bias. So we'd like to look at this data sometimes, and we say, okay, well, we had two groups of patients, and one group had the surgery, and one group did not have the surgery, and we don't see a difference, or we do see a difference. But that doesn't mean it was because of the surgery. Because sometimes there's a big difference between the types of patients who would have surgery and would not have surgery. So, for example, if you're sitting there with a patient and you're discussing with them the risks, you're probably more prone to do surgery because the risks are a little bit lower in a younger patient, in a healthier patient with fewer comorbidities. Or a patient may choose to do the surgery or not do the surgery due to a variety of factors. And so you end up with some sort of result that may not be because of the question that you're asking. So is it the surgery or not the surgery? Well, you could look at these graphs and say, gee, one is better than the other, but it has nothing to do with the actual intervention. It has to do with the fact that the two groups of patients were different. And so really what we need to do in this situation is do what's called a prospective randomized trial. We need to take patients with a positive sentinel node and randomly assign them to either do the surgery or not do the surgery. And many of you here have been broached about clinical trials and randomization. And randomization is hard. It's difficult for patients because you have a preconceived notion, your doctor has a preconceived notion about what might be the better way to go, and what we're really asking you to do for the benefit of others is to sort of close your eyes and take that step forward and just let the roll of the dice decide what we're going to do so that we can really eliminate that bias. Because if you still have that selection bias, it can make it difficult to interpret the results. Well, there have been 2 studies that have been published recently where we did exactly this. Patients were randomized between a complete lymph node dissection or observation. They had positive sentinel nodes. Half of them went back and had the remainder of the nodes removed. Half of them did not. This is the first study. It is from Germany. It was about 41 hospitals across Germany. Now, they were hoping to really get well over 1,000 patients into this study, and unfortunately, they only got about 400. It was a difficult study. Again, you're asking patients to sort of roll the dice about whether they're going to have a major surgery or not have a major surgery. And as you can see, a lot of patients may be more hesitant to sort of not be active in that decision making. But they were randomized between surgery and observation. And the bottom line is there was no difference. The patients who had surgery did not live longer, and this is a graph looking at survival. The ones that had surgery did not live longer because they had that surgery. The patients who had observation did just as well in terms of overall survival. Okay? But again, it was a smaller study, did not get as many patients into the trial, and the more patients you have in a study, the easier it is to detect what might be a smaller benefit. So, for example, if you have 1,000 patients in a study, you may be able to detect whether there's a 10% benefit to your treatment, to your surgery, to your drug. But if you have fewer patients, you may miss that, okay, just because you didn't have enough patients. And 10% benefit in survival, which could be missed in a study like this, might be important to patients. And so everybody kind of looked at this study and said, okay, that's interesting, but we have another big study coming that's going to have more patients, so let's wait and see what that showed. And this is that study. This is the MSLT2 trial. This was, again, a randomization between surgery and observation for patients with a positive sentinel node. This is a worldwide study. It was done here in the United States, and Michigan was a major contributor to this. It was done in Europe. It was done in Australia as well. And so here we had almost over 1,700 patients in the trial. No difference in survival again. So there was no difference in the long-term survival of the patients who had the surgery versus those who didn't. If you look at the patients who recurred in their lymph nodes, so Dr. Harms just spoke about how there's different types of recurrences. You can have those local recurrences. It can recur elsewhere in the body. But what we're really talking about here is you had a positive sentinel node underneath your arm. If we did the dissection, there's still a risk that the cancer can come back in that area. It's important to point out that even in patients who've had a complete lymph node dissection, that isn't a 100% guarantee that the cancer can come back. But here was only about 8% of patients who had a dissection had the cancer come back. If they did not have the surgery, there was a 15% increase in the risk of the cancer coming back, so about a 23% chance of the cancer coming back if you didn't have the surgery. So there is a benefit to the surgery, at least in controlling the disease in that area. Now, here's what's very challenging, and here's what's difficult when we talk to patients. Many people across the spectrum of cancer equate the word recurrence with death. Many people think that if the cancer comes back, that's it. And that's not true. As you just heard, there are different ways the cancer can come back. And some of those can still be treated and cured, and some of them can't. And so just because cancer comes back or there's a higher risk of cancer coming back doesn't necessarily mean more people are going to die. And that was exactly the case here with this study. Yes, there's a higher risk of the cancer coming back in the area, and that may be important to reduce. We'll talk about that in a second, but that doesn't necessarily mean it translates to more people being alive in 5 years or 10 years. Now, why not do the surgery? Even if it doesn't benefit survival, why not do the surgery, at least to lower the risk of it coming back in that area? Because, of course, the surgery has risks. And the most significant long-term risk of these operations, depending on the site of the operation, is lymphedema. Now, these are rather extreme pictures of lymphedema. We really don't see lymphedema this extreme, but there aren't a lot of pictures of mild lymphedema on Google. But they did look at this in the study, and as would be completely expected, the patients who had a lymph node dissection, about a quarter of them did develop lymphedema. And that requires management, physical therapy, exercise, massage, but most commonly the use of the compression sleeve or the compression stocking to stop the arm from swelling up. The risk of patients who were on observation developing lymphedema was quite low, 6%. And I should point out it's 6%. So even those patients who had just a wide excision and a sentinel node biopsy, some of them can develop lymphedema. It's just not very common. But here's what's really important about this study that tends to get missed a little bit when people talk about it. When we say observation, that did not mean that we didn't do the surgery and then we said, we're all done, go ahead, nothing more to do. When you were randomized to the observation arm in the MSLT2 trial, you were randomized to very close follow-up, and the follow-up was not just physical exam, it included ultrasound of the basin. All right? So we can detect cancer coming back in the lymph nodes by physical examination, but you have to have a node large enough that we can feel, and as you can imagine, depending on the size of the patient or the body habitus of the patient, it might take longer for us to detect a palpable recurrence. So ultrasound is a way that we can actually look at the lymph nodes and start to detect early changes in the node that might signal to us that the cancer is coming back in the lymph nodes way before we would actually be able to feel that with physical examination. And this is important because, same as we talked about before, getting back to the whole idea of trying to catch it early if it is going to come back, if we can palpate it, it's got to be large enough for us to feel. And in the time it took for that node to get large enough to feel, you might have had that metastasis to other parts of the body. Whereas if we use the ultrasound and we can see the abnormal node when it's much smaller, we can cut that time between when we notice the node coming back and when we go back in and remove it and hopefully stop it from coming back. And that's what this trial was. It was a randomization between having surgery or having very frequent follow-up with ultrasound. And so for those patients who choose not to have the complete node dissection, it's important they be able to come back frequently so that we can do the ultrasounds and we stay on top of that. So if a patient has a positive node, can they avoid a complete lymph node dissection? Yes, I think safely they can. We have 2 randomized trials now showing us that, and there are advantages and potential disadvantages. Obviously, the pros are avoiding a second surgery, the inconvenience of that, the side effects, the morbidity, the lymphedema, and we can do it without compromising overall survival, which is really probably the most important thing. It does require that ultrasound surveillance, and so patients who don't think that they can or it's inconvenient for them to be coming back every few months, we do it every 4 months for the first 2 years, every 6 months for the next 3 years, and then yearly. Those patients should maybe consider doing surgery. There is a higher regional recurrence. If you don't have the surgery, there's a higher chance that it will come back and you will need this surgery, just not everybody. And the benefits of that may change depending on where the melanoma is. So, for example, the risks versus the benefits of doing a removal of the lymph nodes under the arm might be different than those in the groin, and might be different than those in the neck, and the implications of having the cancer come back in those areas might be more significant in the neck than it might be underneath the arm or in the groin. It's also important to keep in mind, and this is where things get a little bit confusing. We talked about selection bias when we look backwards, and everybody does these prospective randomized studies in order to remove selection bias, but it doesn't completely eliminate bias. The bias may not be between the two groups, but now when you do a prospective randomized trial, there's still the possibility of a bias in terms of who went into the trial, and here's a good example of that. So you can see this one patient has very minimal disease in their node. And a lot of times when patients come back with a positive sentinel node after their first surgery and we're talking to them about the pathology report, we talk to them about here's how much melanoma that we saw in the lymph node. And we have known for a while, in fact, due to research done here at the University of Michigan, that when you have very tiny cells or just a small amount of melanoma in the node, that correlates very strongly with whether or not we're going to find disease in the remaining lymph nodes or not. It's a very good predictor. So you can see a patient with very minimal disease burden. The patient may be very willing, knowing that there's a low risk that there's cancer in other lymph nodes, to go into the trial. The doctor, knowing that there's a low risk, may be very willing to put the patient on the trial. But what about the patients who had 2 nodes positive or who had more bulky disease in their lymph nodes? Both the patient and the doctor may have a bias, and they may not have put that patient into the trial. And that's exactly what happened in the MSLT2 trial. There was a shift, a bias towards patient with more minimal disease. The median tumor size burden within the lymph node was less than 1 millimeter. So what about the patients with a little bit more disease in their lymph nodes? Does the results of the trial really apply to them in the same way? And that's why we don't absolutely have answers. You can try to stratify, you can try to tease that out from the trial, but it's not always that easy to do, and it's not very clear. All right? And so that leaves us still with some questions. So, does every patient with a positive sentinel node need a complete node dissection? No. I think we can safely avoid a lot of the complications. But we do know that doing the node dissection will improve regional control, meaning stopping it from coming back in that area, by about 15%. Here's where we have to weigh those risks versus the benefits. What are the risks of the cancer coming back in that area? Is it worth avoiding? That might depend on, are we talking about the neck? Are we talking about the axilla? Are we talking about the groin? It may depend on the age of the patient. It may depend on the body habits, other comorbidities, other reasons why one patient may have more risks to the surgery than another patient, or one patient may have more benefits to regional control. But it does not appear to improve overall survival. Okay? There are several retrospective studies and 2 prospective randomized trials that show that. But again, these are new studies. These are reported with median follow-ups of about 5 years. The statistics are based on about 3 years. We know that melanoma can come back 15 years, 20 years down the road. It's a little bit unusual from other cancers in that regard. And so maybe the results at 3 years or 5 years, maybe if we follow patients out for 10 years, you might start to see a change. And we're doing that. We continue to follow all of the patients on this trial out 10 years so we can get a better idea. We just don't have those results yet. So there's still some questions. And there may be some subsets that benefit more from the surgery than others. Maybe younger patients. Maybe patients who have more disease burden within the node. These are still open questions that we have to discuss with every individual patient and try to stratify their risk when making that decision. And it's also just important to point out, this is not a choice of surgery versus no surgery. It's a choice of surgery versus close observation, meaning if we're not going to do surgery, we want to see you back every 4 months, clinical examination, and an ultrasound of that regional basin. Thank you very much for your attention. Thank you for the invitation to be here.